I'd like the two of you to comment on a particular aspect of the use of posaconazole that I've heard at my own institution. In AML, I do believe in the data showing a survival benefit of posaconazole in patients undergoing induction chemotherapy. But one of the concerns that some of my colleagues have about posaconazole is the GI absorption, and they make requiring food and making the case that patients are often not eating during this, they have mucositis. And so they say, well, maybe we should use another drug that might be absorbed better. On the other hand, in that very same population, we have randomized data showing a benefit. How do you deal with that?
So actually, maybe a few years ago, we've been using the oral suspension of posaconazole, where it can interact with food, and have to take it with high-fat meal diet, and absorption was an issue. Now with the new formulation, actually, we don't see this impact of.
So we made the leap.
Yes.
The randomized study showing the survival benefit with posaconazole was in fact the suspension, and so when the oral formulation came out, we sat down and said, are we going to allow this extrapolation to occur? We were having such problems with voriconazole and its concomitant side effects.
Yes.
We made the leap 2 years ago. We've been very satisfied with the results.
So especially when you look at the levels that we are achieving in the blood with the new formulation is pretty high, and it happened. It it's quite predictable.
We're pretty confident that they're getting good levels of posaconazole, and in fact, we are using. It is important though to remember we do like monitoring levels of azoles, and having a good assay at your institution or available to you so you can follow azole levels in these patients is important.
right.
So
Yeah,
that
at
is
least especially when you're treating. For prophylaxis, at least for
not so much for
posaconazole,
prophylaxis, of course,
because it's predictable kind of level that you're gonna achieve. But yeah, absolutely for treatment, or when you have a breakthrough infection, you always look at the level. Was it really a failure of the triazoles, or is it the infection is so invasive?
In my AML population, I found that a little bit hard to apply because the turnaround time from commercial labs, at least, has been a while. Is that an issue?
And I think now within 48 hours, 70 hours, you can get the result of the level. Depends which lab you send it to and who's doing it. So it can guide you actually.
The trickier thing with the azoles, and again with posaconazole, is we're forced to become pharmacologists because they do have drug interaction issues.
Yes.
The patients are routinely on calcineurin inhibitors. So I have patients that I'm controlling their graft versus host disease with a calcineurin inhibitor at a certain level, and it's the azole that's keeping it at that level. If I decide it's time to pull the azole out, boom, down goes the tacrolimus level or what have you, and you get a flare of GVH. Right. So
absolutely, you have to keep a close observation.
So not only are you rounding with the ID guys, you have your pharmacist.
We do.
Service.
Of course we do.
Because you have to in this situation.
Yes.
Okay, and of these drugs that we use, my recollection is itraconazole was the one with a more variable, metabolic profile.
Yeah, actually, with itraconazole, it used to be the main oral probably drug for mold-active infection in the past, more than 10 years ago, because of the amphotericin and either the lipid formulation or without the lipid formulation, it is a toxic drug. So itraconazole, the issue with itraconazole, we didn't have great experience with this drug. First, it wasn't active as a prophylactic as much as we would like to, or even treatment. Levels are not predictable, and also the side effect. When you go with a higher dose of itraconazole, it's pretty common and could be serious sometimes. So, and I don't think anyone is using itraconazole anymore.
No, I have not seen that used in well over a decade.
But there is, of the drugs we talked about, posa, fluconazole, and voriconazole, there is a fourth drug that I've heard of, oral antifungal. Can you tell us more about that?
Yeah, the isovuconazole that probably you're alluding to. It's a newly approved drug. Actually, it has an indication for invasive aspergillosis as well as for mucormycosis, although the data, it says for small cohort of patients. And my experience with it, it's still a good drug. There's not much of clinical data published already.
That's the problem.
This is the issue. Yeah,
okay.
That's why.
The supposed advantage, or one advantage that's been brought up, is potentially less of a CYP3A4 interaction effect. So maybe it's not going to drive my tacro up so high.
Right. Yeah, but we're waiting for more data. But I think
really, yes. The simple truth is we've gotten very comfortable with posaconazole since that came out. So the oral formulation, not the suspension.
So I think we've covered what I wanted to cover for invasive fungal infection, unless there are any other comments that you wanted to bring up.
I would just say, going back, and I know you know this is true, from 15 or 20 years ago when fungal infections were killing our patients, it's not a problem anymore, is it?
It really isn't a problem anymore. I'll tell you the biggest problem that I see in my AML population, and that's one of diagnosis. You have a patient with persistent
Sure.
fevers, you have pulmonary infiltrates that are suspicious for invasive fungal infection, but because, and I think it's because we use so much prophylaxis, I can't remember the last time I had a positive BAL, and yet we send all of these patients when they have low counts and they're sick for bronchoscopy. I mean, so what do you think about that?
I think, you know, what we're seeing now, actually, the one who get into trouble with invasive fungal infection, the one who are not on prophylaxis.
Yeah.
And for many reasons. Could be either toxicity or they thought that was the patient not at high risk for fungal
and the
infection.
third one is their insurance didn't cover it.
Also,
Yeah.
absolutely. Yeah, unfortunately.
Yeah.
It happened more often than we like to see.
Okay. Well, let's